We can
Uh,
start, Nilima.
I think so. Yeah, it's 8:34.
Yes, so very good evening, all of you. I'm your host and moderator for today, Dr. Nilima Shah. I work as Associate Professor in the Department of Psychiatry at NHL Medical College, Ahmedabad. And today we have this webinar on behalf of the Women and Child Mental Health Subcommittee of the Indian Psychiatric Society Western Zonal Branch. And the topic is ADHD, Attention Deficit, Hyperactivity, and Beyond. The speaker for today is Dr. Zindadil Gandhi. At the very start, I request Dr. Sudhir Bhave sir, who is our president of the Western Zonal Branch of the Indian Psychiatric Society, to please say the welcome address.
Yeah. Thank you, Dr. Nilima. It's again a great pleasure being here and witnessing one more of those wonderful programs that your Women and Child Health Mental Health Subcommittee has been doing very consistently and regularly. I think we are really privileged to have Dr. Zindadil Gandhi with us today from Philadelphia, because I learned that he's a wonderful speaker and an expert in especially the area on which he's talking. Now, when I read this topic, inattention, hyperactivity, and beyond, I think, as I said just now, I grew interested in what this beyond means. I mean, we all know that with regard to pharmacotherapy, I mean, there is not much new in the treatment of ADHD. But when it comes to psychological treatments which are available, I think there's a wide array of treatment, and not all of us are experts in that. I mean, much work is being done in the future of children who have ADHD and what they turn.
Sir, you are muted.
So with these few words, I end here. And I again congratulate the subcommittee for these programs. Over to you, Dr. Nilima.
Thank you very much, sir, for your motivational words as always. Also, I would like to add, I love the background that you've used full of books, giving that sort of an academic vibe to all of us. Thank you very much.
That is to create an illusion of being scholarly, as you often say.
That's wonderful. Thank you, sir. I request Dr. Ritamra Mehta as the chairperson of this subcommittee to please say a few words as well.
Welcome all. I see more than around 49 participants who joined. That's great. And every third Friday, we are having this webinar on women and child mental health alternatively. Thanks to the West Zone branch of IPS, Dr. Bhave and Dr. Fai and all the other subcommittee members also. We are all very active members, all women, that to reiterate. And today, I'm very happy to see Dr. Zindadil Gandhi. He happens to be person from Gujarat. So welcome, Dr. Gandhi. And we actually, rather than waiting for long, I would request Nilima to introduce him fully, and we start the program. And let's learn from him.
Thank you, ma'am. I would now like to introduce Dr. Zindadil Gandhi. He was my senior at Baroda Medical College during residency, and when I reached out to him to sort of participate, be a speaker in this webinar, he was more than ready. And he said that this is going to bring him a sense of nostalgia as well. So I would like to share his CV briefly. So he completed his postgraduate training here at SST Hospital and MS University of Baroda in 2007. After that, he did his general psychiatry residency. He completed it in 2011 at Albany Medical Center, New York. And by 2030, he completed his child and adolescent psychiatry residency from Drexel University College of Medicine, Philadelphia, after which he also did psychoanalytic psychotherapy training from the same center. He was appointed as faculty from 2013 to 17 at the Department of Psychiatry, Rutgers Robert Wood Johnson Medical College. And from 2018 till date, he works as assistant professor at the Department of Psychiatry of Drexel University College of Medicine, Philadelphia. He has certifications from the American Board of Psychiatry and Neurology Psychiatry and American Board of Psychiatry and Neurology and Child and Adolescent Psychiatry from 2013 till date. He's also received a Master Clinician Award in recognition of clinical excellence and dedication to the patients of University Behavioral Healthcare by Rutgers University Behavioral Healthcare. And he was in 2024, very recently, listed as a top child psychiatrist, top physicians of South Jersey in the South Jersey magazine. He is a member of various prestigious organizations related to psychiatry and psychoanalysis and has several remarkable publications in the field. Today, he's going to talk about ADHD, attention deficit hyperactivity disorder. He's going to focus not only on the core symptoms, but the other symptoms beyond inattention and hyperactivity. And later on, he's also going to focus a little bit on how ADHD presents in adults with special focus on women. So with that, I give over to you, Dr. Zinda Dil Gandhi. It was a pleasure having you here, and I'm really looking forward to your talk, as we all are.
Thank you very much. Thank you very much, Dr. Bhave, Dr. Mehta, and Dr. Shah for your kind words. So without further ado, let's get started. I will be sharing my screen, and please pardon me if I do not succeed. I'll give it my best try. Okay, so the topic that we talked about, we decided to talk about today is the attention deficit hyperactivity disorder. How usually by the name, we focus on attention, inattention, and hyperactivity. However, I believe very strongly that this is more like a tip of an iceberg, and there is a lot more underneath. That's what we decided to talk about today as well, and beyond. So declaration, I do not have any monetary gain in today's lecture or discussion. I do not get any reimbursement from any pharmaceutical company or any other organization which is involved in any product or any kind of merchandise related to ADHD treatment and diagnosis. I do not attempt to infringe any copyrights. So any type of tools, scales, or any other methodology or any equipment that we discussed today, I do not intend to sell it or cause any issues with merchandise. I am a member of American Academy of Child and Adolescent Psychiatry. And to simplify our discussion today, we'll keep the gender discussion to male and female. By doing this, I do not mean to neglect or minimize any LGBTQ issues. So we will attempt to talk about ADHD. We will talk a little bit about the diagnosis because I do believe that DSM-5 or DSM, American Psychiatric Association, has done a really good work by.
Sorry to interrupt. There's a request to keep it as slideshow, your presentation.
Okay.
Yeah, that's fine. Thank you.
Now, all right. Yeah, I had a screen sharing. That's why I believe it happened. Okay, so we'll talk about. I will bring some presentation that I have witnessed in my practice and the clinics that I have attended in the past. We will then talk about some assessment, treatment, various support and accommodation. Now, This could differ from place to place, from country to country, and from city to city, depending on what is available at a particular place. And then we'll open up the discussion later on. Okay, so just starting with some fun, the case of Dennis the Menace. This is not a case I saw in my practice, but just thought of bringing it out, right? Dennis is a very energetic, trouble-prone, mischievous, but a well-meaning boy, right? He gets into trouble. He gets in tangles with his neighbor, Mr. Wilson. He does not mean any harm. However, he cannot stop harming the neighbor. The case of Bart Simpson. Simpson, the junior, right? He's very argumentative. He intentionally irritates people. He intrudes with others' stuff, right? He's very impulsive, right? Even in the show, they show that he gets diagnosed and he gets on this medicine. It's kind of a mockery of a medication called Focalin, a methylphenidate product in America, Focusin. And it's also shown that he has had some reactions to that. In this particular picture, I guess he's shown to be getting some ADHD diagnostic testing. The case of Mr. Bean, we all know him very well. Mr. Bean, it's of course in this show, he's not diagnosed with ADHD, or he does not mean to portray himself as an individual with ADHD. However, those who have seen this show can very casually and easily relate that a lot of symptoms and signs that he shows are signs and symptoms of ADHD, hyperactivity, inattentiveness. If we talk about the beyond, especially for Mr. Bean, him being an adult, we've seen him only when he's an adult. We understand that he has always had difficulty in social situations, right? His fidgetiness, his distractibility has caused a lot of difficulties in social situations. And within the show, there are so many scenarios that are depicted: him being in a church, him being in emergency room waiting area, him being in trains, planes, etc. So just wanted to bring this up. What is ADHD, right? Attention Deficit Hyperactivity Disorder. The whole disorder, the whole condition is just labeled as attention deficit and hyperactivity. It is like, so when I think of that, I feel like, do we call influenza cold and fever disorder? We don't, because we know that influenza has so many other things that an individual can experience, including but not limited to muscle weakness, lethargy, malaise, fever, cold, of course, those symptoms. So that is why I feel that maybe it would be a better justice to this condition to re-diagnose, to rename it, that includes other issues that an individual with ADHD can experience. We will go through some diagnostic criteria, which are created by American Psychiatric Association Press in the Diagnostic and Statistical Manual. There is recently a DSM-5 TR published. I do not believe there is a major difference in the diagnostic criteria in ADHD in TR versus 5, right? It is portrayed as an ongoing pattern of inattention, hyperactivity, and impulsivity, or both, right? There must be at least 6 symptoms in each cluster. So if it is a prominently inattentive type, then there has to be at least 6 symptoms that one fulfills at a time. For adults, though, 5 symptoms suffice to conclude the diagnosis. The same thing with hyperactivity cluster as well. These symptoms should persist for at least 6 months at a time. And usually the onset should be at childhood, but if not, then at least marked or noted by the age 12 years. And more specifically, that this symptoms should present in in at least two settings. So for a child, it would be usually home and school. For an adult, it can be home and work environment, or home and other social environments where the adults are involved on routine basis, regular basis, right? In the inattention cluster, there has the criterias are not paying attention, making careless mistakes because of not paying attention, right? Struggling to maintain the attention, appearing as if one is not listening, do not follow the instructions that can lead to failure of work. Um, Struggling to organize the tasks and activities, leading to a very poor time management and lack of submission of assignment on time. Avoidance and dislike of tasks requiring sustained mental effort. Tendency to lose the important items, right? Misplacing items. The adults end up misplacing their keys, their wallets, and other important items pretty frequently. What would happen? They would be late. They may be late or they may be delayed from the very beginning, but this may contribute to further lateness. Easy distractibility to outside stimuli, and forgetfulness in daily activities, forgetting to do simple daily tasks. These are the symptoms and signs of inattention cluster. The hyperactivity cluster, there is frequent fidgeting, inability to sit still or remain seated when expected, running around. Yes, usually seen in children running around, climbing inappropriately, inability to engage in leisure activity quietly. The person appears fidgety, appears to be on the go, not being able to sit quietly when it is expected, talk excessively, blurting out the answers before the question is even completed, struggling to wait for one's own turn, and interrupting others or intruding others' conversation and activities. So these are some inattention and hyperactivity criteria. Do patients always present with these symptoms? I mean, it would be great for us clinicians if that happens, but many times, not necessarily that becomes a presenting symptom or a presenting complaint. So I would want to discuss some cases that I have come across. I mean, in my practice and my career as a child and adolescent psychiatrist, I've seen many cases who I have diagnosed with ADHD or who have presented with previous diagnosis of ADHD. However, this few cases kind of really stand out. And for our discussion purpose, I would like to present them. To also understand how presentation can differ or differ from the DSM criteria. Please understand that upon examination, all these patients did fulfill the ADHD criteria, DSM-5 criteria. However, the presentation was not the same. So for children, this is a case of a male, a case of J. This is a very remarkable case for me. I mean, this is one of the earliest cases that I came across, and my doubts about ADHD kind of really cleared up. Many of us know, right, that there used to be, and there is still an anti-ADHD movement in psychiatry happening. Like there are psychiatrists who believe that there is no such condition like ADHD, and it is been created by pharmaceutical companies or certain other psychiatrists for various reasons or motives. I have read those psychiatrists and their explanation and their logic as well. And when I started my training in child psychiatry, I was aware of those logics. This case particularly kind of really helped me understand that there is ADHD, it exists, and individuals really suffer and can benefit from treatment. So this is a 4-year-old male I saw this child in Children's Clinic in Philadelphia, presented with a very young mom. She must be in her early 20s herself. And the child could not sit, was running around, jumping around from chair to chair, from chair to floor, attempt to even climb up the table, and almost like on here we're kind of a Red Bull, right? I'm constantly moving around. And I did the assessment for this particular case. It wasn't that difficult. It was a male child showing hyperactivity. The presentation given by mother fulfilled all the criteria for hyperactivity. So the diagnosis itself wasn't that difficult. However, when I started the assessment, a part of the assessment which we will discuss in detail, is to check the baseline vital signs: height, weight, blood pressure. When I asked him to take off his shoes, the hyperactivity that he was engaging in was so much pronounced that he ended up hurting his toenail, and it was bleeding. This child must have been an excruciating pain. 4-year-old with bleeding great toe. Yet he was having his eyes was tearing up. Yet this child could not sit down and sit still and cry. It was very difficult for me to experience this. I mean, I could relate, I could see the pain. Yet the child was so much into the hyperactivity fidgetiness that he wiped out his tears and started running around again. Mom started crying. We eventually finished the assessment, and I prescribed him treatment. And then I did a follow-up evaluation, and there was a pronounced improvement in the hyperactivity domain. And that I thought that sharing this experience with you would be really helpful. The other case is a female case of children, the case of A. I saw her in my private practice, a 5-year-old girl presented brought in by parents with complaint of disruption, defiance, and tantrums, severe tantrums, which would last for 30 minutes in classroom settings as well as home. These tantrums were so pronounced and were so spontaneous and abrupt that they had required a one-on-one staff, means another adult who would be supporting the parents as well as supervising the child constantly, and make sure that the child, the behavior is kind of controlled to the safety, degree of safety. And the parents were frightened by this 5-year-old female child, that she can blast off at any second without them knowing what would be the antecedent or what would cause that. In adolescence, one case that was striking is a male, a case of M, presented to me at age 14 years. He was a freshman in a high school, means a 9th grader. In America, those who do not know, the school system is divided into elementary school, that is usually 1st grade to 5th grade. Middle school is 6th, 7th, and 8th grade. And then high school is 9th through 12th grade. So we'll talk about that transition in a few minutes. But he was in the transition phase, the first year in high school, and he presented with panic attack. A male adolescent presenting with panic attack and severe anxiety. The attacks were coming with him believing that his friends would leave him, will not let him be a part of the groups. Parents were very upset and concerned. Otherwise, this child was an intelligent child, getting A grades, getting into a very good high school, but having these panic attacks and anxiety attacks that significantly interfered with his capacity to then perform academically. In female adolescent, the case I wish to bring up is a case of E. This is a recent case that I have seen, and I'm still working with this this individual. This individual presented in a partial care program. Partial care program is more similar to kind of a daycare program that we have in India as well, or a halfway house kind of a program in which the person attends the program from a kind of a 9 o'clock to 9 a.m. to 2 to 3 p.m. Monday through Friday. For the purpose of addressing severe presenting symptoms. This female adolescent teenager presented with cutting behavior, making cuts by blades, razors, or other sharp objects on her skin, on her body. And they were so pronounced that parents and school as well were very much concerned with this behavior. In adults, the one presentation was for males, a case of D, which is a 32-year-old professional. For sake of privacy, I would not disclose his profession, but 32-year-old professional with valedictorian in the high school and Simna and in college as well, presented with after a discharge from a hospital for having a brief psychotic episode. He was hospitalized for treatment of a brief psychotic episode, which was found probably due to excessive marijuana use. And he also was engaging in excessive gambling. So the diagnosis on discharge from the hospital, the short stay hospital, were brief psychotic disorder and a psychotic disorder secondary to a substance use, and then various rule outs like bipolar, schizophrenia, etc. And a female case of J, is a 38-year-old mother of two. Children were around 5 and 3 years age, presented with severe anxiety, constant shame and guilt that she was not a good mother, and it was affecting how she presented to her own children. So these were all cases with different various presentations. However, they all were later on diagnosed with ADHD and were treated. So steps in evaluation. For a child, when a child is presents here in child psychiatry practice or child psychiatry clinic, it is a common practice to do the evaluation either at a stretch for around 2 to 3 hours, or break the evaluation into a part in which the parents are interviewed and then the child is interviewed and examined separately. The whole evaluation lasts for anywhere between 2 to 3 hours, or could be longer if other assessments are involved. So parent interview is is very important in the evaluation. Asking the parents about, of course, all the symptoms, signs of ADHD, inattentive, hyperactive cluster. Asking very detailed questions about the presenting issues. I mean, if you notice all the previous cases that I discussed, many of them had a presentation that was completely different than a classical ADHD presentation. So asking all the details about the presentation and how the ADHD symptoms kind of complicate their presentation. Child interview and child assessment, right? For any inattention or hyperactivity kind of a clusters, in a mental state examination with child interview, of course, it is age appropriate. So with young child, very young child, you basically do various activities, maybe some games. I have some puzzles of various complexity. I have Rubik's Cube and similar toys of various complexity. And I also have various books in which they can either draw or they can color certain cardboard games as well. So I engage with them in terms of like playing the activity that they want to pick. One of my observation is to see how long they can maintain their attention into one activity, or they need to move from one to the other activities. So even when it's a very young child, maybe preschooler or elementary schooler, and do not participate in a classical mental state examination or interview, a lot can be observed just simply by their activities in the office. Reports from school for children, especially, there are reports from schools, the teachers report, the records, if they exhibited disruptive behavior, defiant behavior, or oppositional behavior, did it lead to any kind of disciplinary action? Here, there are various levels of disciplinary action that a school takes. That could include some warnings. And if the warnings are failed, then in-school detention, then in-school suspension, and then out-of-school suspension. And some of the disciplinary actions are actually reflected in report cards as well. So if these children are exhibiting this behavior that has anything to do with ADHD or fueled by ADHD and not attended to, they may end up getting this behavior recorded in their report cards, and that can reflect into further in their academic achievements in future. For adults or adolescents, adolescents, we can also receive information from schools, but individuals who are not in any kind of academic institution like schools or colleges, we can receive collateral information from close friends who know this individual very well for a significant length of time, as well as family members as well. So parents, or if they are in a relationship, their partners or spouses. The questionnaires are a very important part of the assessment because many of these questionnaires do not necessarily only include attention and hyperactivity. They also include various comorbid conditions. So for an example, Vanderbilt assessment tool, which has a good specificity, sensitivity for up to age 12. SNAP-4 can be used for older individuals as well. Connor rating scale is a copyrighted material and has a specific methodology of assessing and showing the results. And for adults, when we do not have any other collateral information, at least the beginning could be by the ADHD self-report scale. When ADHD is in doubt or various other comorbid conditions are suspected, a neuropsychological assessment can also be done. In neuropsychological assessment, one commonly used assessment is called IVA-2, which is an integrated visual and auditory continuous performance test. So it's like a computerized assessment tool to evaluate the visual and auditory attention and kind of a response control. There are other tests also created for the similar purpose. Some non-psychiatric practitioners like neurologists or certain pediatricians who want to treat ADHD or focus on ADHD treatment, they use what's called a NEBA system. It is FDA approved, but it is approved to understand the brain activity and to provide the insights into the patient's neuropsychiatric condition. For an example, what it means, it shows a certain EEG activity in certain parts of the brain that can be that can result because of ADHD. However, it is not diagnostic that presence of such activity means the person has ADHD. So there is a limitation to this testing, or that is this assessment. However, it's very unfortunately used by certain neurologists or other practitioner as a way of confirming the diagnosis. And another test that is used is called QB test. It's similar computerized assessment test. So the individual is asked to sit in front of a screen, and they are asked to press a button when there is a specific symbol or a specific color would show up. And based on their speed of response, they judge like attention span. And again, this is also a very indirect manner because so there's so many conditions that can lead to difficulty with attention. Simply talking about like neurological, neurotic conditions, anxiety, depression, as well as psychotic conditions that can definitely affect one's attention span and capacity to maintain attention significantly. In the assessment rule out, it's very important from the very beginning to rule out medical conditions. Anemia, when there is a significant anemia, moderate to severe, can affect one's attention and capacity to perform. Various thyroid conditions, hyperthyroid condition can also lead to difficulty with attention. Lead toxicity in America, there is a rule. I think that pediatricians do a lead level for children at a certain age. And individuals who have resided in housing that was built before 1974 or 1970s, because lead was used in paints as well as certain pipings, they should go through lead levels as well, because lead toxicity can lead to neurological issues and the neuropsychological issues as well. And Lyme disease. Lyme disease is prevalent in America, certain parts of America's Northeast America. So the states of New Jersey, Pennsylvania, New York, Connecticut, Delaware, Maryland, etc., and some other parts of America. They are spread by deer and other rodents and other rabbits and other rodents by tick. And children who play in playground on grass or go to woods, or adults who go to woods for hiking or trailing can get exposed. Lyme disease is diagnosable by various antibody testing and is treated. However, if it remains untreated for a long period of time, then there can be certain permanent or long-lasting neurological or neuropsychological complications that can be expected. So it is important to evaluate for these conditions. And of course, for adolescents and adults, substance use is also a very important condition to evaluate and rule out before we conclude the diagnosis of ADHD and propose treatment. Differential diagnosis. Many times ADHD presents with or presents as various conditions. So here I would like to talk a little bit about the beyond and the difference in the presentation by gender as well. Men are more prone to present externalizing symptoms. So men can present with many times oppositional symptoms, defiance symptoms, conduct disorder symptoms in younger age, or antisocial symptoms in older age. They may also present with a lot of substance use or other impulsive behavior, as I mentioned in my earlier case, gambling, or other conditions. Men and women of adult age of driving, they are prone to have more accidents, vehicular accidents. And also, they are more prone to engage in, as I mentioned earlier, antisocial activities. So they may also be may end up presenting for legal issues or medical legal issues. Women tend to present more with internalizing symptoms, which could be neurotic symptoms like anxiety, depression, some psychosomatic symptoms, various pains, and other physical limitations. The presentation-wise, the women present at a later age because of various capacity in way of masking the inattention, especially when they do not have a severe hyperactivity component, masking various inattentive symptoms. Also, the social norms, social cultural norms may also contribute into a delayed diagnosis of women. And many times, as we discussed earlier, that women do not get diagnosed with ADHD and they present with comorbidities like depression, low self-esteem, guilt and shame. And in terms of the presentation at a particular time, men or boys or males are diagnosed, they present almost up to 4 to 16 times more frequent than the women would be. So differential diagnosis, all the present other conditions that could be present need to be investigated simultaneously and treated as well. If when the diagnosis of ADHD remains uncertain or the comorbid condition remain uncertain, in that case, a psychological or a neuropsychological testing really helps. So not just, as I mentioned earlier, not just to confirm a diagnosis of ADHD or not to confirm the symptoms of ADHD which are present or signs present. It is also to confirm various conditions, depression, anxiety, bipolar, various personality condition as well. Because especially for women at older age, many times they present with cluster B symptoms, histrionic or borderline symptoms, and they unfortunately tend to get diagnosed. And when they do get diagnosed with borderline and bipolar, we understand that there is a degree of stigma in public as well as our mental health population, that it can be very easily, ADHD can be very easily forgotten and cannot be treated. Or if there are substance involved, then the ADHD practitioner may shy away from prescribing treatment if that includes stimulants, which are controlled substance. Moving on to the assessment. Vital signs are very important to assess, as I mentioned in that case of a 4-year-old boy. Height, weight are important because various treatments can contribute to some delay in the growth trajectory. However, that does not mean that those treatments are contraindicated in any individuals who are children who are not growing as expected. Treatment of psychiatric conditions are always determined on the basis of risk and benefit ratio, which is very similar in ADHD as well. Blood pressure, various medication, as we are aware, affect one's blood pressure. So a baseline blood pressure assessment is also very important. And then frequent assessments are also important to rule out any kind of worsening of blood pressure or pulse rate or rhythm. Rule out a cardiac condition, heart condition, which is very important in children as well as adults. Massachusetts General Hospital has a cardiovascular screen. I believe it is accessible by public. I think all practitioners are welcome to use it for a clinical purpose. So this is what it is. It kind of asks questions about various kind of symptoms of any cardiac condition to individual, as well as importantly, family history, and then baseline blood pressure and heart rate. Okay. So moving to the treatment part, very important part of treatment in ADHD, especially to improve the compliance and adherence of treatment, is psychoeducation. So whosoever is the presenting individual, if they are parents with a child who has ADHD or the adults themselves, explain to them what is ADHD, kind of the beyond part, how it is affecting one's life. Many times they are not able to put one and one together. That, oh, I am not able to complete my assignment and I'm behind. They believe the self-esteem may make them believe that there is something lacking in them. That can lead to a lot of perfectionistic approach, and that can lead to further delay in completing the assignment. So an education to those individuals about how ADHD can affect or is affecting their current life is very important. What can happen to them if ADHD remains untreated? I think it is also very important to explain to parents as well as the adults. Many of them are already presenting because they have faced the consequences. And some of them maybe, especially when they are referred by school or colleagues, and parents are resistant in receiving treatment, then it is very an important step in treatment to educate them about possible consequences of untreated ADHD. Treatment options, as we are aware, there are medication and psychotherapy and various therapeutic interventions. Medications, when they are discussed, discuss the mechanism of action for stimulants, non-stimulants, possible side effects, drug reactions, drug-drug interactions in case individuals are put on multiple medication to address multiple presenting issues. When explain them the limitation of the medication efficacy and the importance of use of other therapeutic interventions like CBT, cognitive behavioral therapy, focusing on the executive functioning training, social skills group, etc., depending on the individual. A lot of individuals, adults especially, they have difficulty falling asleep. In evenings become more difficult for them to regulate and to kind of manage an appropriate time to sleep, and they remain sleep deprived, which worsens the ADHD the next morning. So explaining good sleep hygiene is also of an important part of treatment. I do not mean to go in detail. I believe we all are aware of which stimulants are available, which non-stimulants are available. I'm more than willing to discuss about anything specific if anybody has a question when we discuss question. I mean, we go with the question and answers. There is a new molecule I would like to quickly share with you is this viloxazone, newer in America. I'm not sure if it was put in market earlier in India or subcontinent. Viloxazone is a specific norepinephrine inhibitor, reuptake inhibitor. So somewhat similar to an SNRI, some similar to atomoxetine. It has come as recently put in market. In clinical data, I do not see any superiority of this molecule over atomoxetine. However, marketing literature says a little somewhat superior in terms of side effect profile and simplification of dosing, assessing the dose to an individual. If we give stimulants, then this is one of the tools to assess the side effects that a child or an adolescent can face. So it's pretty much the list of possible side effects, and it's tabulated so that it can be checked at a baseline and then checked repeatedly to assess the effect of stimulants. I did want to talk a little bit about the interventions. How are we doing with time?
I think, Dr. Zindadil, we could have 5 more minutes of.
That's good. That's sufficient. So, one of the very important non-pharmacological intervention in ADHD is to kind of expand our treatment out of medication management and recommending some therapeutic tools. So, what is it? When it is a child, a school-age child, presenting with issues in school, there are accommodations. Here they are called either 504 accommodations, that's a law that was passed by federal government, or individualized education planning. So this basically are psychiatrist letters asking or requesting the school system to provide accommodation to the child or the adolescents in the school to minimize the interference happening in their academic performance because of ADHD. So here, it is not expected that the child is treated completely and that would be it. It is expected that the school system pitches in the treatment, becomes a part of the treatment, and provides accommodation to the individual so that ADHD does not lead the child to not achieve to their best capacity. So some of the examples of this intervention are giving the child little longer time to complete an assignment. When the child has difficulty to complete an assignment at one stretch, maybe breaking the assignment into various parts, letting the child take a test, maybe give a little longer time, or untimed testing. And also at times, allowing the child or student to take a test in a quieter environment where there are less external stimuli. These are some of the only intervention recommended in school setting. And as providers, as treatment providers, we continue to assess these individuals at various time of their life. So certain milestones, important milestones are when a child enters a school setting, there is an expectation, a disciplinary expectation, a transition to middle school. In here, middle school, they have to go from one class to the other to attend different subjects. So that's a big transition. They are given like a locker. They have to put stuff in the locker, bring it in every class, and then go back. Transition to high school, a lot of expectations, a lot of homework, a lot of clubs, and actually expecting the teenager to take over the responsibilities. So again, if we do not intervene at this level, what is expected out of them is that they take over, they take care of themselves, no help, which can be extremely difficult to have a successful transition. And then to college. And at adults, when we treat adults, certain lifestyle milestones are also very important to address and watch for. One's first job, marriage or wedding, moving into with a partner, pregnancy and childbirth, milestones when the children are growing up and they are achieving their milestones. Because ADHD, we don't know exactly what's causing it, but we do know that there is a strong familial component. So when one important part of assessment is also to assess the family members or the parents or other family members as well. They may have ADHD as well. That may require treatment or intervention. Quickly going through some challenges. When the comorbidities are present, address them immediately. Do not wait that ADHD will take care of those comorbidities, especially when they are something that can affect one's personality or self-esteem. I mentioned about side effects education, minimize polypharmacy as we all should do. Right? So that is it about ADHD. We are open for question answers. By the way, anybody has any question later on or require any kind of any other information, please reach out to me. Do not hesitate by my email.
Thank you very much, Dr. Zindadil Gandhi, for such a lucid presentation and for keeping it very crisp and clinical oriented. We have certain questions in the chat box. Dr. Radhika Kelkar asks, can you explain more about the adolescent male, why he was diagnosed with ADHD and not anxiety? The adolescent male case that you talked about.
Yes.
She wants you to elaborate.
So, right, that's a very good question. The presentation was, of course, panic attacks and anxiety, and as the treatment was immediately started to address that by an SSRI and psychotherapy and interventions in school. The anxiety and panic attacks, the panic attacks subsided. However, the anxiety persisted, and it shifted from being anxious about remaining in groups. It shifted to academic performances, completing the assignments on time. And that led to the evaluation for ADHD. This child, the adolescent, did not fulfill hyperactivity criteria, but then doing a thorough evaluation helped me understand that as the ADA, the anxiety was kind of treated, the ADHD unmasked into having difficulty with attention, easy distractibility, zoning out, and not completing the assignments. That would all lead to the anxiety. As this is how I diagnosed that individual with ADHD and added the treatment of ADHD, continuing the treatment for anxiety, added the treatment of ADHD, and that led to significant improvement in academic performance and self-esteem.
Thank you, sir.
I think that's how, yes. Yeah, I guess that's how you say that it's the tip of the iceberg. The presentation is something different, but at the root cause, there are symptoms of ADHD causing the particular presentation. Another
Yes.
question by Dr. Radhika is what is the best treatment line for ADHD, for adult ADHD with inattention component?
What is the best treatment for adult ADHD with inattention? I think the
Yes.
first line treatment recommended by US FDA is stimulants. Even with adults, stimulants are by and large, and the recommendation, assessment, and all those what I mentioned, they remain kind of very persistent. So medication management, and within that, stimulants are the first line treatment for inattention. And actually, if you look at the FDA indication, all the treatment, medication management, especially stimulants or non-stimulants, are indicated for inattention part. They do help with hyperactivity. However, the primary indication is inattention subtype. So that is something to understand, including all these stimulants and non-stimulants.
So,
Thank you.
methylphenidate or modafinil?
So no, modafinil or they are not a primary indication. They do not have a primary indication of ADHD yet. They are used when other stimulants are failed, or the individual has, in my understanding, if they have any sleep disorder that requires Provigil or modafinil kind of stimulants. But they are not primarily used for treatment of ADHD. I am not aware of any data that would indicate use of them over methylphenidate or amphetamine salts.
Okay. Is viloxazine, the new molecule that has been introduced, you talked about, is that FDA approved yet?
Yes, it is.
Dr. Garima is asking.
Yes, it is. It is approved by
Yes,
FDA
it is.
for treatment of inattentive subtype.
Okay. Dr. Parag Dhoble has a comment and a question. Great presentations, Indadil Bhai. Sir, you have worked in both Indian and American settings. Have you noticed any difference in presentation and treatment of ADHD? And what is the role of nuclear versus joint family and social support, etc.? Please also share your experience on clonidine.
Okay. So I'll try to remember all three components of the question,
And
but
remind you
remind
if
me, Dr.
needed.
Nilima, if I miss any.
Sure.
Thank you, Parag Bhai, for this question. So my experience in Indian setting is limited to 3 years of residency. And I remember that at that time, ADHD, I'm talking about 2004, 5, 6. So I remember that atomoxetine was kind of a newer molecule that came in and we started using it, and it did have good effect. I do not recall what diagnostic tools or questionnaires I had used at that time. So I think I would say I'm not, I wouldn't take that responsibility of like an individual who has exposure to both settings or platforms at a similar, experience. The second question about the difference between a molecular, a nuclear and a joint family. I can kind of speculate or hypothesize. I believe that when one is in joint family, especially having retired grandparents or retired older elderlies, I think they can definitely contribute to helping the parents taking care of the child. And I think that support many times help. Now, does it mask ADHD or does it cure ADHD? I don't know. I don't have a data. But I think there is no doubt that symbiotic or a healthy functioning joint family has advantages over nuclear family. That's I think obvious, and I believe research also confirms that. And the third question about clonidine, the long-acting clonidine form, clonidine ER, which could be either 12 hours or 24 hours, is approved by FDA for treatment of ADHD. However, in guidelines, it is not routinely used as a first-line treatment. It is used when the stimulants cannot be used for various reasons. One could be if there is a suspicion of substance use or abuse, or if there are adverse reaction of stimulant, or if there is severe growth retardation or severe retardation of achievement of growth with stimulants. I think in that case, long-acting clonidine can be used. One has to be aware of side effects of sedation as well as postural hypotension. So when clonidine or guanfacine are used in treatment of ADHD, especially long, either frequently 2-3 times a day or long acting at a dose of around 3 to 4 milligrams of guanfacine or 0.3 to 0.4 milligram of clonidine, one needs to repeatedly check postural hypotension, blood pressure for postural hypotension as well.
Right. Thank you. The next question by Dr. Garima again. Why the adult female was not diagnosed with major depressive disorder and rather ADHD? And I would add on to that question, how do you really differentiate whether the inattention component is due to depression per se or it's an independent ADHD going on?
Yeah, so I think we can definitely use the DSM criteria to differentiate. In that condition, again, the presentation was non-ADHD presentation, right? I understand Dr. Garima is talking about the 35-year-old female that I discussed,
Yes,
who presented with anxiety about her children, a low self-esteem and a lot of shame and guilt.
Yeah.
So of course, the patient was had actually she was previously treated for anxiety, depression, to an extent that the treatment included of the first line treatments as SSRIs or SNRI or even atypical antidepressants, including adjunctive treatment of mood stabilizers and second generation antipsychotics as well. So that led me to understand that if multiple therapeutic interventions are failed to address the depression and anxiety, then there could be something else going on. And this ruminations, another atypical presentation of ADHD could be this kind of a rumination or preoccupation into certain thoughts. So it may appear like OCD kind of a symptom, but it could be, it definitely requires an assessment for ADHD. Now, when that is suspected, then of course, going back to the DSM criteria and see that if the individual is fulfilling the criteria in adult, 5 criteria for inattention. So those criteria were fulfilled at a time for a period of at least more than 6 months. And I did ask the individual to also provide me any past information, if she has school records or past diagnosis, or if any parent present. I do not believe that I talked to any parent for this particular case, but that is also something that can be done. Who the parents can give us a very detailed information about what was happening in the childhood for this individual, and etc. etc. Many times parents are able to tell us that how intelligent or capable these children were, but then just the inattention or other activities or impulsivity led them to kind of have a very deviated life expectation.
Please share your experience of treating children of age group 4 to 6 years using pharmacotherapy. Use of clonidine, what is the dose, side effect, and tolerability versus the choice of going only with behavioral therapy? How do you decide that, and what is your experience with that?
Yeah, that's a good question. For 4 to 6 years, in fact, the stimulants can be used. Short-acting stimulants can be used to treat individuals. The case that I discussed, the 4-year-old boy with severe hyperactivity, I treated him with Ritalin, a plain methylphenidate, short-acting, very low dose, 2 milligrams or 5 milligrams, couple of times a day or 3 times a day up to, because they are short. Children have faster metabolic rate, so they should give medication like slow and low and slow. So very slow, low doses, and titrating up very slow, watching the side effects very closely. They may require frequent dosing. And 6 years above, all the long-acting stimulants, including non-stimulants, which are atomoxetine and Quilbri, are approved by FDA. Clonidine can be used. And I believe it also requires a similar monitoring. to watch the kids for development of any kind of lightheadedness or postural hypotension. So I would use stimulants when they are indicated in younger children as well. Talking about 4 to 6 years age. I'm not talking about like a toddler of 2 years or 3 years. They are treated with more of like a behavioral intervention in which parent is a very important component of the participant in the treatment. There is a model of such treatment. It's called floor therapy, in which parent, therapist sit down with the child on the floor and kind of help the child redirect and attempt the child to learn to enhance the attention span into one activity. So at earlier age, toddlerhood, those kind of behavioral interventions are used. But for severe hyperactivity or to a degree that the child is getting hurt often, stimulants should be used. Again, kind of a risk versus benefit ratio. I would, however, have a pediatric cardiologist involved when I'm treating with any individual kind of off-label for a stimulant to make sure that there are no CVS consequences.
Any data on comparison of long-term follow-up of ADHD who were treated and who were not treated?
A lot of data, actually. So I may be a little scattered explaining that, but untreated individuals, as I was mentioning earlier, right, that they have higher rates of motor vehicle accidents, so higher rates of morbidity and mortality due to accidents. They have higher rates of morbidity and mortality due to impulsive behavior. So that could expand into some illegal criminal behavior as well. They are more prone to hold and carry firearms and weapons. They are more prone to also have legal consequences. So I don't have the exact data on percentages, but there are higher prevalence of ADHD in prison inmates than community sample.
Yeah. Dr. Shikhar in vogue. People want to be diagnosed as such. In such cases, how often present their symptoms? So, and what further steps can be taken?
Nilima, I'm sorry. Can you repeat the question?
So what if
There is a delay in the. Okay, I think you're back. Would you mind repeating the question, Nilima?
yes, so that was, sometimes people think that they have ADHD, especially adults, and they overrepresent their symptoms on self-report scales. So what do we do in such cases?
That is a challenge that we all face as clinicians. And one factor is to gather the collateral information. Were they previously diagnosed? Is there any medical record of those earlier diagnosis and treatment? And if not, then if there is any parent or other significant other partner or friend present who can confirm this diagnosis. Now, at the same time, we also assess for any substance use, any wish to get the controlled substance and then to abuse them or to redistribute them, means to sell them off the street. So that is always a challenge that a practitioner faces when they're presented with an adult for the very first time with ADHD symptoms. There are some neuropsychological testing that can be done to understand if there is ADHD or not. However, there is possibility that they may not necessarily help us conclude or especially rule out a diagnosis of ADHD in adults.
On the same lines, have you seen misuse of stimulants or on feigning adult ADHD symptoms? Have you come across such cases?
Yeah, I think stimulants are at times misused, and not just by adults, adolescents as well. Unfortunately, use of short-acting stimulants are not uncommon in college settings, dorm settings, taking it before the exams, kind of all-nighter kind of preparation for exams or other performances. They are, and then there are stimulants which are illicit, like methamphetamine and other stimulants which are also abused often. So there is always a chance for such. There is a system called prescription monitoring program that is currently active in Americas, which basically is an online platform that provides the information on an individual, what medication, what control substance was prescribed by a particular practitioner to this individual, in what quantity, what direction, and all that. And all the various states participate. So you have capacity, the practitioner has capacity to look up for various states and kind of assess whether this individual is getting kind of doctor shopping and getting substances, the controlled substances from various prescribers or not, or getting controlled substances earlier than they are prescribed for. However, there is a chance of an abuse or redirection of a controlled substance.
Okay. There are a couple of
I
questions.
just want to
more.
add one thing into that. I'm sorry, Dr. Nilima. So
Yeah, sure.
Vyvanse is a dexamphetamine. Vyvanse is a molecule that is created especially to minimize the abuse of amphetamine salts. So when taken, this tablet form, the way it disperses in our body, that it does not give that high that can be experienced by an individual who uses high quantity of short-acting stimulants. And it does give a persistent effect for anywhere between 7 to 10 hours based on the individual's metabolic state. And also, if it is crushed or broken to get the stimulant out of it, when it's misused, abused, or redirected, it loses its component. That's what it's claimed by the pharmaceutical company who has created this particular medication form. So that can be used. And of course, then if we are really suspicious about abuse, we can move the treatment to non-stimulant treatment.
Right, right. In patients with ADHD and depression, comorbid, should atomoxetine be preferred over methylphenidate?
Only in case methylphenidate contributes to mood changes. If methylphenidate itself is not causing any adverse reaction or side effect, then I would still prefer methylphenidate over an SNRI. Why? Because if you think about drug-drug interaction, methylphenidate is easier with other SSRIs or SNRI than an SNRI and another SSRI or an SNRI. So in that way, I would say methylphenidate is safer to use unless there is a drug reaction that I find.
And there are various nice comments, very elaborate presentation. Thank you for sharing clinical insights and very nice webinar. Will there be a recording available? I missed the first half and things like that. So a lot of compliments and a lot of thanks. And
Thank
indeed, we had a very, very interesting presentation followed by a very nice question answer session. You really, that thing stays in my mind, that influenza does not mean just cold and fever. So similarly, ADHD is not just inattention and hyperactivity. Even if the clinical presentation is suggestive of anxiety or depression or even of brief psychotic disorder, as you mentioned in one of the cases, we have to look for the underlying cause, and we have to rule out whether there is presence of ADHD or not. Because as you said, it could be just the tip of the iceberg, the symptoms, and the root cause may actually be ADHD. So we should always have an open eye for that, even in adult patients. You also elaborated on how a detailed assessment can be done and what are the treatment modalities and how, we should choose a molecule very wisely. We could also use methylphenidate for 4 to 6 years old, you added, because here we feel that, up to 6 years of age, it is advisable to not use because of the growth retardation and things like that. But thank you for sharing all your expertise and clinical experience with us. And with that, I think Dr. Ritamra Mehta, if you're there, please say some concluding words before we all say goodbye to each other.
Oh, yes, I think Dr. Gandhi, you have really done justice to this topic, and we really learned a lot, especially from your background, the US background, that you have really given your clinical experiences. You have shared all these experiences so well. And yes, definitely, when I was in UK, that's why we asked this question that people came with adult ADHD scales and they demanded these stimulants and how to deal with these. You have really given us many good tips. Thank you very much, sir. We really appreciate that you have shared your wisdom. Thank you, sir.
Thank you very much. Thank you very much. I'm very glad to be here. Thank you for having me. I appreciate that.
Thank you, ma'am. Thank you, all the participants, for being here. Despite all the competing webinars, all those who have been here, thank you for your attendance. And goodbye until next time. Good night. Good day, Dr. Zindadil.
We
Thank you very
crossed
much.
60, and that's a great